I'm Dr. Brannon. This is a video demonstration of release of an incarcerated medial meniscus. We are using superior arthroscopic portals and the clear cannula positioned between the patella and the femoral sulcus. Shown here is our standard positioning. No special apparatus is required. We have the clear cannula, which has been inserted through a superior and lateral portal. You can see it is positioned between the patella and the femoral sulcus. We can explore the knee, and indeed we have identified substantial synovitis along the medial aspect of the knee where the patient is complaining of significant pain. We have additionally established a superior medial portal, and again, the clear cannula is displacing our patella anteriorly. The noted chondromalacia of the patella can be easily addressed as well. We have established an inferior lateral portal, as noted with the nitinol wire. We have now moved to exploring the medial meniscus using the arthroscopic mirror. And one can note that there is a degree of chondromalacia or eburnation of the medial femoral condyle. And we strongly believe this is a result of abnormal weight bearing or abnormal meniscal mechanics during the range of motion. We are exploring the posterior and medial aspect of the knee. We're ranging the knee, and we are noting that the posterior medial corner of the meniscus appears to be incarcerated posterior to the medial femoral condyle. Again, we strongly believe that this degree of eburnation or chondromalacia of the joint surface in this young patient is a result of abnormal meniscal mechanics. The arthroscopic mirror is simply positioned inferior to the meniscus. We will then range the knee and further demonstrate the degree of incarceration. After having made this observation, it becomes clear what the surgical objectives should be. We're now entering into the far medial aspect of the knee, or what is more commonly known as the medial gutter. We can readily visualize an early osteophyte that appears to be forming along the medial femoral condyle. It is thought that during the range of motion of the knee, this upslope of the medial femoral condyle causes the medial subluxation of the medial meniscus. As this osteophyte enlarges, the meniscus is more likely to become incarcerated, as observed here. We are continuing our debridement process, and again, we are using a superior lateral portal, that is superior and lateral to the patella, passing through the clear cannula, which is positioned between the patella and the femoral sulcus. The arthroscopic shaver is passed, is positioned through the superior medial portal. As this early osteophyte is removed, we will range the knee and further examine the meniscal mechanics. We can see the most medial aspect of the medial meniscus. And we have switched to a 70-degree scope so that we may observe the extent of this early osteophyte posteriorly. And now we can readily observe how throughout the range of motion this osteophyte appears to cause the subluxation of the medial meniscus. The arthroscopic shaver is positioned quite posteriorly, and we are taking down this osteophyte that has led to the incarceration of the medial meniscus. These are non-traditional portals. One may easily approach this same area through a traditional anterior, medial, and inferior portal, but we found it's far easier to access using a superior medial portal, and then at the same time we're able to range the knee and truly observe the meniscal mechanics. You can see as we range the knee that it appears that the meniscus is moving more laterally, or one should say it is maintaining its position between the tibia and the femoral condyle. And you can see as the knee is flexed that perhaps this osteophyte was inducing the medial subluxation of the meniscus. Visibility is excellent, and our degree of debridement appears to be satisfactory. We have found this observation to be particularly important when treating patients with chronic knee pain and early osteoarthritis with mechanical symptoms. Continuing our debridement process, we can range the knee and observe more anatomic positioning, if you will, of the medial meniscus. We can then return to looking at the medial meniscus more directly. And we want to compare this degree of mobility and the positioning of the meniscus to the initial view where it appeared to be incarcerated posterior and medial to the medial femoral condyle. I'm Dr. Brannon, and thank you for watching.